Pharmacogenomics doesn't just influence drug metabolism, it also plays a critical role in how drugs are excreted and how they interact with their targets in the body. Pharmacodynamics. Calcineurin inhibitors like cyclosporin and tacrolimus are widely used for immunosuppression, especially in organ transplantation and autoimmune diseases. They work by inhibiting calcineurin, which leads to reduced IL-2 production and decreased T-cell activation. However, these drugs are dose-dependent and can be toxic to the kidneys. One key factor in their excretion is P-glycoprotein, or PGP, an efflux transporter encoded by the ADRB1 gene. PGP pumps drugs out of cells to reduce intracellular accumulation. It plays a protective role in kidney cells, helping to remove CNIs. If a person carries certain genetic variants in ADRB1, PGP activity may be altered. This can reduce the drug's clearance, leading to higher intracellular concentrations and a greater risk of renal toxicity. Because CNIs are PGP substrates, pharmacogenetic testing may help identify patients at increased risk and allow for individualized dosing. Pharmacogenomics does not only influence pharmacokinetics, LADME such as CYP enzymes, it is also noteworthy that critical genetic factors that influence drug response at the target site, aka pharmacodynamics as well. For some therapies, it's not just how the body processes the drug, but how the drug interacts with its target that matters. That's where pharmacodynamic gene testing becomes essential. For example, in cancer therapy, testing for genes like EGFR or HER2 guides the use of targeted treatments. Receptor polymorphisms can influence the efficacy of cardiovascular drugs, and enzyme variants, such as those affecting methotrexate, impact response and toxicity. Pharmacogenetic testing helps identify specific gene variants that influence how patient responds to a drug. For instance, SLCO1B1 variants reduce hepatic uptake of simvastatin, leading to higher plasma levels and an increased risk of statin-induced myopathy. ADRB1 variants in the B1 adrenergic receptor gene can affect how patients respond to beta blockers like metoprolol. Some may experience a poor therapeutic effect. DHFR mutations in the dihydrofolate reductase gene may cause resistance to methotrexate, especially in cancer or autoimmune diseases. In some cases, polygenic effects where multiple genes interact could drive more complex drug responses. For instance, warfarin dosing is influenced by both VCORT1 and CYP2C9. Sometimes drug response is often shaped by more than one SNP. For some conditions, such as drug-induced QT prolongation, multiple gene variants may work together to increase risk. Understanding these interactions helps us personalize treatment, reduce side effects, and improve outcomes.